think is why.
Okay, sir. 8 o'clock ayin, sir. We will start the meeting, sir.
He's unmute, and I can't hear him. Hello.
Hello.
వినపడుతుందని చెప్పండి.
Okay, sir. Namaste, sir. Andarki. Good evening and good morning to all those who are in USA, sir.
Yeah.
So first of all, I'd like to say thank you to Lokesh Garu, who is coordinating this meeting, and special thanks to Dr. Prasad Garimela Garu, Anupama Garu, and Dr. Rakesh from AIMS, Delhi, India, sir. So ఈ మీటింగ్ మెయిన్ ఇంటెన్షన్ ఏంటంటే సార్, కోవిడ్ గురించి ఆల్రెడీ ఇండియాలో కేసెస్ వస్తున్నాయి, కాకపోతే ప్రాక్టికల్ ఎక్స్పీరియన్స్ మాకు తక్కువ ఉంది. సో ఆల్రెడీ యుఎస్ లో మీరంతా ట్రీట్ చేస్తున్నారు కాబట్టి ప్రాక్టికల్ గా ట్రీట్ చేసే వాళ్ళ దగ్గర నుంచి నాలెడ్జ్ షేరింగ్ ఉంటే బాగుంటుందని చెప్పి లోకేష్ గారి హెల్ప్ తీసుకొని, అండ్ అమెరికన్ అసోసియేషన్ ఆఫ్ ఫిజిషియన్స్ ఆఫ్ ఇండియన్ ఆరిజిన్ తరఫున మీరు వచ్చినందుకు స్పెషల్ థ్యాంక్స్ అండి. సో ప్రజెంట్లీ ఇండియా వీ హ్యావ్ మోర్ దాన్ 16,000 కేసెస్. ఆంధ్రప్రదేశ్ మార్నింగ్ బులెటిన్ ప్రకారం 647 కేసెస్ ఉన్నాయి. అవుట్ ఆఫ్ దెమ్ 565 యాక్టివ్ గా ఉన్నాయి. సో 65 కేసెస్ డిశ్చార్జ్ చేశారండి. సో అవుట్ ఆఫ్ దీస్ 647 కేసెస్ 17 డెత్స్. So far now we have 17 deaths. Most of them are aged people with comorbidities. అట్లానే
స్పీకర్ ఆఫ్ ఉందండి.
we have 129 cases. వాటిలో 125 యాక్టివ్ ఉన్నాయి, 4 డెత్స్ అయినాయండి. సో గుంటూరు అనేది రెడ్ జోన్ లో ఉంది. సో ఇప్పుడు వాట్ వీఆర్ ఎక్స్పెక్టింగ్ అంటే, మీరు ఎలా ట్రీట్ చేస్తున్నారు పేషెంట్స్ ని, ఓపీలో ఎలా చూస్తున్నారు, ప్రొటెక్షన్ ఎట్లా ఉంది. మెయిన్ ఇంటెన్షన్ ఏంటంటే సార్, యాజ్ ఐఎంఏ వీ హ్యావ్ టు ప్రొటెక్ట్ అవర్ డాక్టర్స్, పారామెడికల్ స్టాఫ్, అట్ ద సేమ్ టైం వీ హ్యావ్ టు సేవ్ ద పేషెంట్స్. సో ఈ రెండు మోటోస్ మనం ఫుల్ఫిల్ చేయడానికి మీ హెల్ప్ కావాలి. సో అక్కడ టెస్టింగ్ ప్రోటోకాల్స్ ఎట్లా ఉన్నాయి, ఓపీస్ ఎట్లా చూస్తున్నారు, పీపీఈస్, N95s రోల్ ఏంటి, ఆర్ దే ఆర్ 100% ప్రొటెక్టివ్. అట్లానే ఐసీయూలో పేషెంట్స్ ని ఎట్లా ట్రీట్ చేస్తున్నారు, అట్లానే అనస్థీషియా పార్ట్ లో ఇంట్యుబేషన్స్, ఎక్మోలు, ఎలెక్టివ్ సర్జరీస్ చేసేటప్పుడు ఎట్లా మేనేజ్ చేయాలి, నాన్ కోవిడ్ ఎమర్జెన్సీస్ ఎట్లా చూడాలి, కోవిడ్ ఎమర్జెన్సీస్ ఎట్లా చూడాలి, ఫాలో అప్ ఎట్లా, ఇవన్నీ థింగ్స్ we want to hear from you, sir. And at present, because of lockdown, we are seeing only emergency cases like dialysis కానీ, డెలివరీస్ కానీ, ఎంఐస్, స్ట్రోక్స్ అంతవరకు చూస్తున్నారు. కానీ కమింగ్ 2 days లో కొంత ఏదో ఇన్ ఆంధ్రప్రదేశ్ ఆరెంజ్ గ్రీన్ జోన్స్ వాళ్ళని కొంత చూడమనే ఉద్దేశం కనపడుతుంది. సో మీరంతా అక్కడ ఏం జరుగుతుందో మా వాళ్ళకి ఎన్లైటన్ చేయాలి. సో నా విల్ హ్యాండ్ ఓవర్ ద ప్రొసీడింగ్స్ టు లోకేష్ గారు టు ఇంట్రడ్యూస్ స్పీకర్స్ అండ్ స్టార్ట్ ద ప్రొసీడింగ్స్ ఆఫ్ ద మీటింగ్, సార్. థ్యాంక్ యూ.
Thank you so much, Nandan Kishore garu. Can you hear me?
Yeah, sir.
Very good. So thank you so much, and this platform, especially we are going to share between what's happening in India and USA, because we are ahead. Like we're treating more of ICU patients, hospitalized, and so this is just a platform to talk each other. And I mean, it's not that we are teaching you; we are learning more from India. India are doing much better in prevention than in America. We already know that. So first, I will go ahead and introduce Dr. Rakesh Garg. And Dr. Garg is from AIMS, New Delhi. He's MD, DNB, MNAMS, PG, CCHM, and CCEPC. He did fellowship in palliative medicine, I know Dr. Garg from last 2 years while working with the Indian Resuscitation Council with the help of introduced by Dr. Chakra Garu. He also joined our meeting. So with that introduction, he's from AIMS New Delhi. He published many, more than 260 publications and 20 chapters in different books. So I will go ahead and give it to Dr. Garg to take over. He will have 10 slides.
Thank you so much, sir. And greetings to everybody from India. And we are all sailing in the same boat of fighting with the pandemic right now. Is my slides visible to everybody?
Yes, sir. Yeah.
Yeah, it just came in.
Right. So when we talk of the Indian scenarios, greetings from All India Institute of Medical Sciences. At AIMS, we have 2 COVID centers which we have prepared. One we have outside the campus, which was National Cancer Institute, which has been converted to the Onco Center. And we have converted our trauma center at main AIMS into the COVID center. So we have facilities for the isolation center, the ward and ICU, because with our experience, almost 80 to 90% people are requiring mild disease or asymptomatic.
Hello.
Hello.
Prasad. I mean, Rakesh Garu. I think it's disconnected. I can.
Screen is frozen.
So, we'll, I think there's some technical difficulties from Dr. Garg. So, hello, Rakesh? Prasad, do you want to start until Rakesh comes?
Certainly. Can you hear me?
Yeah, let me introduce Prasad Garimella is a pulmonologist. He's at from Kurnool Medical College and presenting, working at Atlanta, Georgia. And he's has been many patients with COVID in the hospital, ICU, ventilation. So Dr. Prasad Garimella, can you please go ahead and start, sir?
Sure. Thank you, RP and IMA, for giving me the opportunity to talk about this. Don't know the clear agenda. I just wanted to tell you about the brief pointers or whatever we learned recently. One of the most important things I realized is like the task force. So the task force for the hospital is one of the crucial factors. So if you don't have one, obviously you need to develop it. The agenda for the task force should be where the ICUs are, what the ICU teams are, what the schedules for those ICU teams are, and what the backups are. And then the PPE, the training, the forecast demand, and prioritizing the diagnostic tests. Those are going to be your critical factors for you as you navigate through this process. So back to the COVID itself, I mean, about 20% of the people who have the COVID are getting hospitalized. Of those 20% of the people, 5% are getting into the ICU. Of those 5% of the people, half of that ICU population or more are getting intubated. So the range is anywhere from 42 to 100% in the ICU, the number of people that are ventilated based on the studies. Our personal experience is like our hospital has about 40 to 45, a range of patients, and sometimes it hit up to 50. About 15 or so is our ICU population. Of that 15, only 1 or 2 are not intubated. So we have a lot more of ventilated patients. So one of the classic features that we saw in COVID is that there is progression to ARDS very, very swiftly. And as you know, like any other ARDS, you have multi-organ failure problems. So about third of them are getting acute kidney injury, about third of them are getting acute liver injury, about third of them or less, about 25, fourth of them are getting about cardiac injuries. So fortunately, we are not seeing the shock phenomenon like we see with other ARDS. So only about 1 out of 7 or about 13% of the patients are getting into vasoactive drugs to maintain the blood pressure. Similarly, about 1 out of 7, about 12% of them are getting secondary bacterial infections. So another classic feature with COVID-19 as opposed to the others is that the PEEP is not the PEEP, the compliance is still very high compared to the other ARDS patients that we see. So what we are realizing is that it is not that hard to ventilate these patients to maintain the plateau pressures below 30. As far as treatments are concerned, you can categorize them into the moderate and the severe. Severe being the ventilated patients, moderate being pre-intubated patients. So pre-intubation, you can go with either low flow nasal cannula, high flow nasal cannula, or non-invasive ventilation. So I think that based on the guidelines, not the guidelines because there are no clear-cut guidelines, there is a lot of theories on how to manage these patients pre-intubation. So nasal cannula, earlier in the beginning of about 2 weeks ago or so, we were saying that intubate these patients early because nasal cannula, either low flow or high flow, or non-invasive ventilation is aerosol producing. So that's going to expose a lot more people in the room to the infection. So we were intubating people early in the beginning, but now we are also keeping a lot of the patients on nasal cannulas and also non-invasive positive pressure ventilation. So I guess Dr. Anupama Garu is going to address that intubation part, but I'm just going to say what are the general indicators of when to intubate. So it is basically rapid progression. The 40 liters or so high flow. I'm not certain in Indian scenario whether you are using the high flow nasal cannulas or not, but high flow requiring more than 40 liters per minute, or the FiO2 requirement more than 0.6 or 60%. That's one thing. And then the increase in the CO2 is another indication for intubation. Then obviously the multi-organ failure and hemodynamic instability are the other factors that you need to consider. So as far as intubation is concerned, Dr. Anupama will go over that. I think one of the things that in our local area, what we thought is like aerosol box. One of our local toy makers who has some acrylic material, he could come up with our own, we could come up with our own aerosol box. It's like a square shaped box with 2 holes. So you pass your 2 hands through those holes, so to intubate the patient without much of exposure. This video went viral from the Taiwanese doctor who's an anesthesiologist or critical care specialist. So he kind of put it out there, and we used that video and got it designed, and we were able to get the aerosol boxes which are transparent. So we made some modifications. We had about 20 of them are made. At least in USA, we could send it out to the people who want because the designer is willing to prepare them. Once it is made, it becomes easier. So it may be a good idea for one of the engineers to work on it in India to mass produce them. Once that initial iteration is done, that is going to be highly protective for the people when they are intubating or doing any aerosol producing procedures. That's about the intubation. And as far as ventilation is concerned, we're still doing the low tidal volume ventilation like any other ARDS at this time. I know there are a lot of videos and a lot of different theories of how to manage them. But at least the current guidelines based on the SCCM guidelines or ACCP or even WHO guidelines, we're all going with this low tidal volume, 6 ml per kg of minute ventilation. High PEEP on an average around 14 or so is what we are using in these people. And the other important thing is if the high PEEP and low tidal volume is not working and the patients are still desaturating, then we are going with prone ventilation. So we are doing about 16 on, 8 off of prone ventilation. One unique thing that we saw is like, unlike the other ARDS patients where we used to use 4 to 5 days of prone ventilation, here we are going almost like 10 days of prone ventilation. And the other other unique thing about this is we are using a lot more paralytic agents, neuromuscular blocking agents in these people to maintain the dysynchrony. And it is also kind of a less, patient movement and more safety. So that's why we are using a lot more of paralytics. Even though other centers have used the ECMO as the other modality beyond all these things, mechanical ventilation, paralytic agents, and proning, ECMO is also very useful and helpful, as you know. At least in our center, we do not have the ECMO. Those are the modalities of treatment. And general pointers in this ICU management, I'm sure we have questions after that. So obviously airborne precautions as much as possible. If you have negative pressure isolation rooms, that's the best protection for you, one of the best protections. Obviously sealing all the ventilator circuits is so vital. What I did is like, in the beginning, we taped all the circuits so that there is no leak happening, because you have so many joints from the endotracheal tube to the ventilator circuit. So each of those joints we kind of reinforced with the tape so that there is no accidental disconnection, because that is going to give a big aerosol load into the room and obviously exposes everybody over there. So tight seals and avoiding the disconnections as much as possible. Inline adapters for any kind of collecting the material, and avoiding the bronchs, and maintaining the cuff pressure on the endotracheal tube around 30 or so. You do not want to have any leaks around the endotracheal tube, that is again aerosol generating. And next step is that I want to address is the extubations. The week that I did, about the last week, we do the 7 days rotation in the ICU. So we had about 15 patients or so. It ranged from 11 to 15 patients. And we were able to extubate about 5 patients and transferred 2 of those 5 patients out. So a couple of days later, they were able to send rest of the 3 out also. So I think the difference with this condition, COVID-19, is that it is taking longer time. On an average, we used to do the tracheostomy by the day 14 or so of any other ARDS patient, and used to send them to long-term acute care facilities. In this scenario, it is taking longer, and nobody is doing tracheostomy, at least in our facility. Everybody is worried about the exposure to all the people involved. So we are not doing tracheostomy. And these patients are taking longer time to be extubated because we don't want to re-intubate them. So for all these reasons, I think it's taking about 3 weeks or so for us to get them off of the ventilator and be able to extubate them. And even after the extubation, they are really very, very weak. And that is taking more time to extubate them also.
Yes,
the CPR and ACLS, I think that's also important aspect, that the task force, or if you are one of the members taking care of these sick patients, need to have a plan for the CPR and also ACLS protocols. And in addition to that, you always have this supportive care. The VTE has picked up some venous thromboembolism prophylaxis is obviously used in all the ICU patients, but heparin as a treatment, even if you don't have VTE or DVT or PE at this time, is kind of coming up to be more and more people are noticing it. At least in our hospital, we have seen more DVTs formed in these people, both in the ICU and also after we transferred. The next day after I transferred, both of them ended up having DVT. So we are considering selectively at this time full dose anticoagulation while they are in the ICU rather than prophylactic anticoagulation. So the sedation, the nutrition, the glucose control, and all those are bread and butter ICU management. But finally, I'm going to end with this treatment options. One of them is the Plaquenil and Zithromax. Like everybody else in the USA, we put the people on Plaquenil and Zithromax. But Monday, tomorrow, we are part of the treatment team for our hospital, and we are going to take out the Plaquenil, given the 2 RCTs that showed that the Plaquenil did not improve. A point of caution over here is that, sorry. So point of caution here is that Plaquenil has a very, very long half-life. For any drug to be very effective, it takes 3 to 4 half-lives for it to be effective. Because we are using only 5 doses, whether that is effective enough, that's why we are not seeing the in vitro benefits that we saw with Plaquenil against the COVID-19 or coronavirus. So that's one of the questions out there. The other question is whether still it is going to be prophylactically useful or not. That is also need to be determined. So the Plaquenil, I think we all know that has some role, at least proven in vitro models. And but as far as these 2 RCTs that came out within the last 3 or 4 days or so have not shown any benefit. So we are trying to get it out. Tomorrow we have a meeting. So obviously there are no clear guidelines at this time, but I'm sure within the next week or so, the societies will be coming up with the guidelines. So the second one is going to be, I'm going to talk about the heparin. Like I said earlier, that heparin is going to be made, I think people have noticed that there are more DVT in this condition compared to the others. So in a patient who has low risk factors, may need to consider full dose anticoagulation and watch for any bleeding complications more closely. The third one is basically the steroids. The steroids, when to use it, and how much dose to do it, and all that is still not out there. SCCM has recommended in around 10 to 12 days of ARDS, they did recommend, SCCM is Society of Critical Care Medicine, but there is no consensus on that. It is not a universal recommendation at this time. Not everybody is supporting it. One of the things that we monitored in our ICUs is like we followed the CRP levels. We also followed the lymphocyte count. As a lymphocyte count is going to be low in the beginning of the course, and lymphocytes starts building up. And when the lymphocytes are building up and the CRP is going up on tracking, that's what one of the things that we thought maybe we can give the steroids at that juncture. If the lymphocytes are still low, they are not going up, and the CRP is relatively low, we are not using it. But if the CRP is going up and the lymphocytes are going up, then we started using the steroids. What dose we used? We used about 1 milligram per kg of solimedrol or methylprednisolone. Others are using dexamethasone 10 milligrams for 5 days. I think it's a tapering dose after the first day of dose with dexamethasone, whereas with solimedrol or methylprednisolone, it's the same dose for 5 days. Whether we have seen the improvement in that patient or not is still, because I used on 2 patients or so, and of those 2, 1 improved. Whether they are improving because of the steroid or not, it's still too early to say. But there is a general consensus to use the steroids. The next one is going to be IL-6 TOSI. I use TOSI in a young patient who is 44-year-old cath lab worker. And unfortunately, his situation was too far out. So IL-6, I think a lot of people are using it nowadays. I did even ask my rheumatology friends to keep some samples out there because the hospital is going to run out of the TOSI pretty soon, unless they have the new supplies that are coming in. What else is in there? Plasma is a big thing for us. Plasma exchange. 1 unit of plasma, convalescent plasma from a patient who recovered. We are collecting it. Our protocol went out 3 days ago. We have used at least for 7 to 8 patients so far. I think the data is still out there. 1 out of those 7 patients has seen worsening. Is whether there is a mismatch or some other antibody response, that's why he gotten worse. It's yet to be known, but at least that is the plasma effect. We still need to know, but I think based on the MERS and SARS data, previously they have used the convalescent plasma and there is an improvement in that scenario. We are taking that in here and using it right now. Obviously, there is no evidence-based clinical trials at this time on the plasma in COVID-19, as far as we know. But that information should be rolling in pretty soon.
Well,
And one last one, sorry, Lokesh garu.
go ahead.
Yeah, one last one I'm going to say is like a lot of questions came about. I think there were some questions sent by Dr. Lokesh very earlier. I think the prognosis depends on not on just the locality alone, but as you know, it is basically the risk factors, the vital signs, and the labs. So those are the combination of those three is going to tell you who is going to make it. So the risk factors wise, what we know is like people with comorbidities, COPD, heart disease, kidney disease. But one of the things that we are noticing is like people who are obese are having more trouble. It is very similar to the H1N1 we saw in 2011, 2012. Pregnant and obese people were particularly at risk for developing severe disease. Similarly here, what we are noticing is people who are obese, if they got the COPD, they got the COVID, they are much more sicker. Then vital signs wise, obviously the respiratory rate, heart rate, and then the oxygen saturation, that's going to be your prognostic indicator. And then the labs wise, one of the things is lymphocyte count, like we discussed, NLR, neutrophil lymphocyte ratio of more than 3. That is also, we are not actively using it, but others have reported it, D-dimer and troponin. So these are a combination of all these risk factors will give you a rough idea of the prognostication.
Yeah, thank you, Prasad. I really appreciate it. And we'll get back, Dr. Rakesh Garg. Are you back, sir? Can you take over? Dr. Garg?
Sir?
Yeah, go ahead.
I'm in.
Yeah.
So thank you so much. Sorry for the interruption. There was something, some issues with the network. So regarding the preparedness, we already had our the document prepared at AIMS, which we are using it, and it is working well. It is working well. So this document is updated on day-to-day basis. And, this is a document that we are using it right now from 18th of April. Now, the point here is in India, almost around to the tune of around 90% patients are in the mild categories or asymptomatic. So probably that is why we are able to manage them in the isolation centers separately, and the requirement of ICU is to the tune of around 5% or so. So the number whichever is coming, we are able to manage them. They usually undergo a symptomatic management rather than requiring some specific drugs as such. The role of HSQS, which has been managed by or which has been advised by the Indian Council of Medical Research, is primarily for those patients who are having some comorbidities. We are not using it regularly for all patients who are coming with mild disease and they are just on symptomatic management. We are using RT-PCR as the standard of tool. We already have received the antibody kit, but that will be primarily for the hot zones, for the cluster zones. Those will be used as a screening tool rather than the diagnostic tool. If we see the total number of cases as of now, 19th April today, by around afternoon, the total number of cases were 13,295, about 519 deaths. So these deaths were usually having a good amount of comorbidities, majority of them, and that's why the isolated deaths in patients who are mild disease is much lesser without comorbidity associated with them. Now, this is a little good point from Indian point of view. Because of the lockdown, we are seeing lesser number of cases, though the number is increasing. But what we are actually seeing is that the confirmed number of cases, the doubling time is much reduced now. Now, the initial surge somewhere in the beginning was a collection of patients who were quite positive, almost around 2,500 patients, and that's why we see a surge. If you see this picture, there was a sudden increase in the number of cases somewhere here, but the lockdown overall is having a big impact. And if you see the recent trends that are happening, the initial doubling time was somewhere around 2 to 3 days, but now the doubling time is going almost very, very I mean, that's increasing, and it is almost going to a tune of 8 to 10 days in the last 2-3 days. So that's a good sign that we are looking for. And this is what is bringing the good effect of complete lockdown in India, not just the complete lockdown.
Yeah.
Mute అయిపోతుంది.
And
He's talking, but I can't hear.
I think the net is problem.
Mm.
So, what is the time? 11:01.
Dr. Garg, we can't hear you, Dr. Garg.
I think we'll come back to, let's go with Anupama, then we'll bring Dr. Garg. Next speaker is Dr. Anupama Gotimakula. She is pediatric anesthesiologist from San Antonio, Texas. They're going to restart the elective surgeries from Monday onwards, and she will be helping us on ECMO and other things. Anupama, please go ahead and start. We'll bring Dr.
Thank
Garg
you, IMA and RP and Lokesh Garu. So here in United States, it's bad, and we had a high number of cases, and so it's giving us a lot of experience how to manage these patients. So we are learning through our numbers. So we typically, anesthesiologists, we follow the American Society of Anesthesia and Anesthesia Patient Safety Foundation. So we follow whatever the ground rules they are forming right now. And it is also evolving, like this week may be different, next week may be different. So what is currently we are doing, I'm going to go over that. So Prasad Garimella Garu explained very well about intubation and all that, ventilation, few things, and I'm going to go more about that. So what are the indications for intubation, first of all? So we try to put the patients on nasal cannula, go up till 15 liters, and still, oxygen saturations are less than 92. So then we decide that this patient needs intubation. So there is no rush to intubate. It's not an emergency procedure. We need a lot of preparation before we go and intubate the patients. So we need protective equipment, like personal protective, without N95, without eye shield, without gown, double gloves, and also we have to take aerosol precautions. So with all these precautions, you go into the patient room. So without any protective equipment, you should not go into the rooms, because you have to, save yourself from infection. So avoid emergency intubations. And when do you intubate? So when the oxygen, you're giving 6 liters, but still the saturation is less than 92, then that is an indication for intubation. And then the person who's intubating should be a very experienced anesthesiologist, highly skilled anesthesiologist. And no trainers and no other people should intubate these sick patients. Also, if there is an opportunity and there is an availability of video laryngoscopy or glidoscope or any kind of equipment, that is better to be used, because you stay away from the patients. Also, we have to do rapid sequence intubation, so to avoid bag mask ventilation. That way you avoid aerosolizations. And also, if at all you don't have intubating stuff ready or you're delaying, then you have to do bag mask ventilation, but you need to have a filter. If you can have a filter, that will filter the virus. Then at the same time, when you are with the patient, you're going to do other procedures also. These patients need other procedures like central venous line, arterial line, sometimes hemodialysis, catheter placements. So you have to kind of do all the procedures at one time, so that you're already wearing all the protective equipment, so you don't want to waste those equipment. We are very short of these protective masks and all. So every procedure should be done in just one sitting. So once we intubate the patient, you're going to put them on the ventilator. So I don't know know how many anesthesiologists are in this group listening to us, but it's a good thing to learn for everybody. So when you put the patients on ventilator, usually it is a volume control ventilation, and you want to give tidal volumes less than 6 ml per kilo ideal body weight, not the total body weight. So, and the PEEP also, you don't want high PEEPs, you are managing at 8 to 12, and respirations at 16 to 20. And also your oxygen, FiO2, should titrate so that your goal of, you have a line, suppose you are monitoring the arterial oxygen, then your goal is to put the oxygen between 55 to 80. You don't have to achieve 100% of or 100 PoAO2. So that's enough for these patients. And also we are talking more about proning of these patients. So proning is helping these patients because there is much better ventilation of the lungs. So that's why we keep them at least 16 hours in the prone position, and then they turn supine to do any procedures or anything, but 16 hours at least every day they are being in prone position. So that's helping the oxygen saturations, which are going from 80s to 90s. So it's a very useful procedure. It's difficult. You need people in the ICU to turn a patient prone. So it needs people help also. And so in spite of these ventilation and all, some patients are not improving. So that's why we kind of going for ECMO. So very few patients go on ECMO. And let me see, let me say what, who are the patients who need ECMO. So ECMO, typically we have a veno-venous ECMO, and these patients are risk of very high mortality, like 50% or higher. When you say 50% mortality risk, that means you have a PaO2 and FiO2 ratios. So 50% mortality risk is associated with PaO2 to FiO2 ratio less than 150 on a FiO2 of more than 90%. So there is 80% mortality risk associated with PaO2 to FiO2 ratio less than 100 on a FiO2 of more than 90%. So this is the mortality risk. You can see how these patients do on ECMO. And also, when the CO2 retention is there on mechanical ventilation, despite you're giving more than 30 centimeters of peak plateau pressures, and pH is less than 7.25, this is another indication for going on ECMO. And also these patients should be less than 10 days on ventilator. You don't want to put someone on ECMO when they're more than 10 days on the ventilator. And also there is an age criteria. So typically in US, we are falling less than 65-year age to go on ECMO. More than 65, they have high mortality and comorbidity, so it's not a good indication for ECMO. So it's more for younger patients and who are really sick. They can't tolerate the ventilator anymore. So what are the advantages for being on ECMO? So you are giving, there is no need for ventilator support. Lung will get some rest, so that will allow lungs to recover and also prevent from exposure to high injurious pressures. Like on the ventilator, we are seeing they are going more than 20 people, so that's dangerous for the lungs. You're causing more damage to the lungs. And also it's very easy procedure. It can be done bedside, and so it helps in improving the oxygenation, better ventilation. So those are the advantages for going on ECMO. So there are some contraindications. So not everyone can go on ECMO. So the major contraindications are like neutropenia, like the total neutrophil counts are less than 400, and lymphocytes are less than 1,000 per microliter. And also when you see the CNS damage like hemorrhage in the brain or major irreversible, non-recoverable comorbidities or terminal malignancy. So these are the patients you cannot put them on ECMO, as well as age more than 65 to 70. So I just want to say, like, I know we are seeing downtrend in the cases right now in the United States. So our anesthesia and everybody is saying like we should start the surgeries, right? I mean elective surgeries, but where do we start? Like how do we start? What are the so there is a timing like for reopening of the elective surgeries. So what we say here in US is there should be a sustained reduction in the rate of new COVID-19 cases in your geographic areas at least 14 days before you start the elective surgeries. So we are following everyday daily cases. Like in my city, we have about 1,000 cases in my town. So we are watching very carefully that the numbers should go down for at least 14 days. I think we are right there on April 22nd. So that's what we are thinking to start our elective surgeries. Also, we need to be authorized by the state health authorities or your local municipal. So you need to get authorization for when to start these elective cases. It's not me, just my individual decision to start the elective surgeries. Also, when you decide to start these elective surgeries, you have to have your hospitals equipped with enough PPEs, enough number of ICU beds and non-ICU beds, also ventilators or medications, anesthesia, and all these supplies have to be there, because once you start doing these elective cases, then you have suddenly a surge of these COVID patients. You will not have beds available in your hospital. You won't have ventilator beds. Right now, some areas like New York and Louisiana, like every ICU bed is occupied by COVID patients. So when that is the situation, how can you do elective surgeries which may need a ICU bed? So I don't want to compromise my elective patients there. And slowly we are starting, like initially when we had the order for no surgeries, we were running only 2 rooms for just emergencies. But slowly from Monday or Tuesday, we are starting 4 rooms now. So we are starting slowly, but we want to see how we can do. So these are not like the elective cases which can wait. These are kind of semi-urgent or urgent cases where we have to do these surgeries. We cannot postpone too long. And then that's where currently we are. And if I have any questions, I will take. Thank you so much.
Thanks, Anupama. Dr. Garg, can you come back? Are you back?
Yeah.
So you can complete, then we'll go to questions.
Yeah, thank you so much, sir. So the advantage that we are getting in India is, as of now, the number of cases are not so much, and they are not overwhelmed with the resources. We had sufficient time across India to develop and procure the various things. So right now, we are able to manage these patients with appropriate amount of PP kit and everything. And we have procured the antibody kit test also that will be primarily used for hot zone areas wherein the number of cases are a little higher, and that will be used as a screening tool. And definitely, in case required, they will be requiring the RT-PCR to be done for these patients. With regards to the management therapies, the HSQS, the hydroxychloroquine, is being used for patients who have some comorbidities, and antiviral therapies are being added for severe category of patients as well. And the healthcare workers are those who are in contact. They have been allowed. It's not mandatory, but they have been allowed to use the hydroxychloroquine as prophylaxis. The good thing is the doubling time has come down from 3 to 4 days to 6 to 8 days now. And I think this is the correct outcome measure of the lockdown, which has happened for last almost 4 weeks now. And the results are very good. And the administration is doing a nice job by curtailing and sealing the areas where they get a cluster of anything more than 6 number of cases. So this is how we are managing right now in India. The situation appears to be under control as of now. And we hope the lockdown will have good impact on curtailing the number of new cases that are happening.
Thank you so much, Dr. Garg. Some of the questions we have, is anyone have questions? Dr. Nandakishore, sir, can you ask questions? Do you have?
సార్ చాట్ లో కొన్ని ఉన్నాయి సార్, ఆల్రెడీ ఆన్సర్ చేస్తున్నారు.
ఓకే.
ఒక్కసారి టెస్టింగ్ ప్యాటర్న్, యాంటీబాడీ టెస్ట్ వాటి గురించి ఒకసారి చెప్పమనండి సార్.
So any new speaker about antibody testing here in USA, Dr. Prasad?
యాంటీజెన్ కూడా చేస్తున్నారా టెస్టింగ్, బ్లడ్ టెస్ట్?
Yeah, the screening test is one of the major tests is done is antigen testing, and either first nasal swab or the blood test, the rapid test. I think Anupam Garu, you're doing all the rapid tests so that you can, if they're negative only, they're doing the surgery, right?
అవునండి. సో మా ప్రతి పేషెంట్ ఇప్పుడు ఒక 1 వీక్ నుంచి వీఆర్ డూయింగ్ ఎవ్రీ పేషెంట్ వీఆర్ టెస్టింగ్ ఫర్ యాంటీబాడీ IgM and IgG. If we have any suspicion, then we are doing the nasal swab test. So the first test we are doing is IgM antibody test అండి. అది బాగా అవైలబిలిటీ ఉంది. క్విక్ రిజల్ట్ కూడా 45 minutes పడుతుంది మా హాస్పిటల్లో టు గెట్ ద రిజల్ట్.
And
So every patient is being tested. Everyone going to surgery are being tested with this.
there is one more information here. Santa Clara County, which is 20 lakhs population, and it's almost like Guntur district is 50 lakhs. Out of them, they did a antibody test for IgG antibody. That is a protective antibody, and they did. I think they have 2 to 4% of them already positive. So that means 40,000 people out of 20 lakhs are positive. So that is actually a good sign. Only 2,000 have symptomatic. So 40,000 asymptomatic, 2,000 symptomatic, and deaths are 100 in that county. So that's what I'm looking at is if this herd immunity comes around 60-70%, we're talking about 40,000 to 2,000. That's probably one way of looking at it. An antibody test will come, and within 2-3 weeks we can get more data information. Dr. Gar, can you, I think you said that there is India getting 2-3 lakhs antibody test. Can you expand on that, sir?
Yes, right. Now we have received the antibody kits which were not available initially, but the antibody testing are being done for the identifying the clusters. So the Indian Council of Medical Research has issued an advisory that in these group of patients, to identify those hot areas means where there are more than 6 number of patients. Based on the symptoms, they will go for the antibody testing, and if they're positive, they will be confirmed by RT-PCR. With regards to the surgical cases, as mentioned by Dr. Anupma, right now at majority of places, the elective cases has not been restarted. Probably the coming week, many of the centers are thinking to start the new things. So the advisory has not been issued. It is being under consideration that what should be our primary modality for considering these patients to be COVID positive or suspect, and what type of investigations we'll be looking for. But as Dr. Anupma mentioned also, I think probably some of the centers have made it mandatory for all elective cases to get an RT-PCR done a day prior. But with the availability of antibody kits now, probably we'll be thinking the same way. The antibody IgM testing, and followed by, if required, the RT-PCR can be done for the elective surgical procedures.
In the screen, in the Zoom, if you have hand raised, anyone want to ask questions, please raise the hand so we can unmute them. There's one more question here about the false positive, false negative test of that. Can you comment, anyone? Garb?
Yeah, false negative is in 20%, Andy. So how do you know this 20% of people are really infected or not? So you can do that nasal swab test. That way you can get, if you do both, it's 100%.
So antigen and antibody test.
Antigen antibody test is one test, and then that PCR test is another, the nose swab, right? So if you do both of them, you get 100% sure that this patient has COVID or not. But if you do only IgG, IgM test, antibody test, you have 20% false negatives.
Dr. Garg, do you want any add on that?
Yeah, that's it. Perfect. I think the sensitivity specificity is somewhere around 70 to 80%, and depends upon the timing also, because even the IgM will start putting up at 3rd to 4th day. So if a patient gets in contact history of a day or 2, even the IgM will not mount and have a positive effect. So I think we need to have some to say that it's 100% specific and sensitive for a particular thing. I think we need to go for the clinical symptoms with history and all those things, in addition to a combination of antibody and antigen testing will give a fair idea. But yes, if any doubt, I think it will be for elective surgical procedures. If we admit a patient, if we can hold for 2 to 3 days to look for the symptoms and for the IgM to mount on, that will be a fair idea that we are looking for as of now, because the incubation period and the antibody mounts will take some time.
We have used, can you hear me?
Yes.
Yeah. So there are cases where the suspicion was very high based on the CT and there was no alternate explanation. In those cases, we did use the second test and the third test. So as far as I know, the second test has about 25%. So in the 20% false negative, you pick up another 7 to 8 on the nasal swab. A lot of that false negativity is coming from the ability of the person who's doing the test to collect the good specimen from the posterior nasopharynx. So the nasopharynx being very, very sensitive, the natural response is for the patient to move back and then avoid the mucosal contact. So I think if they do that well, I think you have better chance. Number two is like if you have intubated patients, we realize that the lower respiratory tract specimen has a higher sensitivity for the same test, like 93% to 95%, as opposed to oral or nasal swab. I'm talking about the swab RT-PCR antigen-based testing. We have not put in the antibody testing into our day-to-day. We are thinking about at least getting the hospital, the doctors, when they come back, to test them all, healthcare providers, and also testing the patients for elective procedures. At one point, we need to restart. So as far as restarting strategy, in a week or two, as our numbers come down, we are planning to use those antibody kits. But the problem with the antibody kits is, like, there was one company, Boston Biopharma, who gave us about 50 samples. I tested many patients who were positive, and we could not get the IRB in our system quick enough. But at least the 50 kits, that samples that he tested, I tested on many of the patients. And unfortunately, there is not a good positivity in those patients. These are the proven patients, proven by antigen. And then I had the IgM and IgG kits to figure out whether that is what the performance of the test is. So I think there are a lot of people who are kind of giving it. So be careful. Because a lot of these companies are coming out from China, so they probably are, like a placebo kind of a thing. They may not have any good reagent in there. So I think go with only approved tests. And I think the FDA approved only few of these IgG and IgM ones, because there are a lot of crooked people out there who are selling these kits. They can just bulk buy them from China and then trying to sell them over here. But the implications are, if you are giving a patient who is positive and they are tested negative, you are getting that positive person to spread that, either asymptomatic or pre-symptomatic person who is antibody negative, that guy is spreading it. So the implications are high.
Next question came from, I think this Rakesh Garg has to answer. How do you reach the herd immunity and put end to the COVID?
Right now, we are not very sure how the herd immunity will be achieved because we are following the social isolation and complete lockdown. So we are not looking for the herd immunity as of now, because that would be against the lockdown phenomena, even to the extent of complete sealing of a particular area. Because if we see the India as a whole, and if we allow the herd immunity, which was being seen in the European countries, the number of cases were huge. So probably at this time, our resources may not be able to manage those good number of patients at that point of time. So probably the lockdown is looking correct for as per our resources availability. And we hope, as you quoted the study, that the number of cases who are mounting antibody is almost 50 to 80 times the number of cases which has been confirmed positive. So we hope that the same phenomena will happen here and our resources will not be exhausted. And that's why we are not allowing to open the lockdown to let the herd immunity happen.
Sure. Other question to add is, I read 235 pregnant women about delivery in New York, 13% are positive. They're asymptomatic. The 30% their blood test is positive for COVID. So in New York, it seems to be much higher than Los Angeles, where they're less. So that's one thing to add. This question to I think both Anupama, we don't have a negative pressure systems in OT. Any solution for the laminar system the same? This is from Dr. Prasanthi, anesthesiology from Guntur. We don't have a negative pressure systems in the operating theaters in India. Is any other solutions?
So the best solution is you have to protect yourself. So you need to protect, you have to have an N95 mask, and then on top of it, a surgical mask. And then you also put a shield, plastic shield. So you need triple protection in that case. And then very minimal people movement inside and outside the rooms. Where before you enter into the room, all the doors should be closed, no doors open, the OR doors. And where your protective gowns donning and offing it is called. So you need people to help you with that. So, and also once you are inside the room, you are continuously with the patient when you're operating on a patient, so or in the ICU rooms. So the minimal movement, maximum protection, and one person most of the times manage inside. Most of the doctors are mostly outside. If possible, we can do video conferencing in from the front desk area where the doctors are sitting to inside the nurse. There's one nurse. So minimum people inside the room. That's where we can protect ourselves when there is no negative pressure. So when negative pressure means the room circulates 6 times in 1 hour or something like that. So the circulation is constantly being taken off from the room, and the doors closed. So the pressures inside are less than pressures outside. So that's why we keep negative from outside the room versus inside the room.
One more thing to add is in China, I think the 40,000 are volunteers who worked in Wuhan. They have complete suit. They covered completely, and whenever they do, and none of them, I mean, I don't know, we have to believe China report, but they said there is no contamination. It makes sense. So those in the war, maybe you have to wear the full suit, completely closed like before.
Yeah. They're called Ebola suit or hazmat suit.
Hazmat suit that zips around that you see. The other question here is, a lot of people in India, especially in Guntur, anyone in India, outpatient clinics. See, here we can control one patient going to the room, exam, and something like that. I do phone call the patient, talk few minutes, but I have not stopped our clinic. But in India, that 100, I mean, they have to see 10 people, 100 people. I mean, maybe family comes, maybe somebody is asymptomatic. How do they protect themselves? Any idea? Any recommendation, Dr. Garg or Prasad?
So I think at this point of time, we need to reallocate or reassign the work culture that we have in OPDs. In our routine OPDs, there'll be say 5 to 6 patients and other members sitting in the same cabin. I think we need to relocate, and we need to redesign the OPD basis here. We have to follow the social distancing. Somehow, if we can have something like a telecommunication, or we can have a performa based instructions or the information that we want to have from them, we have to innovate that idea in our setup also, and that will be usually useful. Now, other thing that we are doing at our isolation center, we can do it for the other patient clinics also, that we are giving them an Wi-Fi's passwords, and we are allowing them to bring their mobile phone into their triage area. So many of the things are being communicated on WhatsApp videos and WhatsApp calls also. So I think this type of telecommunication can be one component of collecting the information when they're coming to the OPD clinics. And obviously, we need to have only one patient at that point of time in the OPD. We need to change our OPD areas a little bigger one and follow the social distancing and other principle of hand hygiene and everything.
Other thing I'm doing in outpatient is we're putting a plastic screen or PVC so that they can a patient can be other side. I mean, a lot of things you can do without examination, medical history and the labs and everything. So you can start that slowly, and as you go move on to that, there's a physical barrier, and you can have a mic other side, or maybe some other things a little bit in a way too. There's one question here. Sorry, go ahead, Prasad.
The couple of cases I heard, one from Kurnool and one from Guntur, is that these OPDs that are run even with this lockdown situations, there are two physicians who died. Obviously, that's a high risk for the physician. So I think it is definitely not a good idea that traditional rural or the OPD practices, especially private practitioners too, where there are multiple patients in the same room, that is obviously a big no-no for everybody. I think it is very important that we discourage, because both the situations, the physicians continue to practice in that setup and then unfortunately succumb to the disease. So that's why I think it is very important. I just want to add on one thing here. So local high school robotics team had a 3D printer. So if you have any access to the 3D printers, I think a simple solution, overnight they made 150 of them for our hospital. This was a big booster for morale for our staff. So what it is like, you can just assemble this 3 units or so. So they printed these things and gave it to us. I think you just put it on like this. And because a lot of it is droplet, unless you are very close to it, it is airborne. I think having N95 mask, having the shield, something like that would be useful. I think local engineers or local people, we should engage them at a, so that they can mass produce or at least have this thing available for these high hotspot areas like Guntur, Kurnool, and Nellore, at least in Andhra. I think we should engage these engineering and manufacturing people to come up with the shields, because that's what is going to happen in the next week or so, that the healthcare workers will lose their morale because they don't have enough PPE. I think the faster we kind of start the preparation, you will be having that morale under control. I mean,
Thank you, sir. I think a few weeks ago I spoke to Dr. Prashanti Madam. Vijay, can you unmute Dr. Prashanti? They locally they made these gowns, also the plastic covers, etc., to cover with the material like a raincoat, something like that. Meanwhile, go ahead, Prashanti. Can you answer?
Yes, sir. We got some OHP sheets. Am I audible?
Yeah, please.
Yeah, we got the OHP sheets, overhead projector sheets we used to write in our younger days. So we stitched them to the surgical masks. So we made those masks with face shield. We made around 1,300 of the type, and we gave it to the fever hospital staff and GGH anesthetists. And a few of them are being bought by our local IMA members also these days.
So probably need to supply the whole surgical and whole outpatient Guntur, madam. Next question, there is a dermatology question. I think I'm not sure we can answer. I have to read and get back to it. It's from a question from Dr. Kavita, dermatologist from Guntur. I'm getting a varicella-like lesions here in adults with a history of childhood onset of varicella lesions. Should I ask them to have a testing for COVID? They're otherwise with no systemic symptoms. My answer is yes, because there's a lot more we are learning. This is the main meeting is not we teach, we're learning from you, from India, I mean. So it's like some of them we are ahead of the these intubation, acute care. So definitely I will test for COVID because we need to learn a lot. Next. Next question is please suggest any biomarkers frequently used in ES to pick sick patients early?
D-dimer is very well used, and D-dimer is used to guide the anticoagulation therapy, especially not just the prophylaxis, but full dose anticoagulation. Then I used CRP to see when to start the steroids. So the good thing with the CRP is like you need to track it, not just one number. It's more like a trending of that CRP may be useful. And others have used a similar path. And then acute, the total lymphocyte count or ALs, lymphocyte count and NLR is the other one that is useful.
Okay, next question. Can you unmute one of the one want to ask questions, Vijay Garu? Someone raise the question, hand. And the name of them so we can tell them they're unmuted.
Dr. Ramakrishna.
Dr. Ramakrishna Garu, can you please ask your question?
Hello.
Yeah,
Sir, am I audible, sir?
Yeah, yes, go ahead, sir.
Sir, when do you start using tocilizumab in your patients when you admit the COVID patient in ICU?
Okay. COVID, Prasad, can you answer?
Honestly, we used two doses Sunday. We used only 2 doses. That's information that I got. So basically 8 milligrams per kg, 2 doses we gave him. And unfortunately, that patient ended up being sick, but people are using only 2 doses.
And you do with steroids and tosi together?
We are using it because it's like a Hail Mary. So you are throwing out everything that you have at this time, in these people.
Okay. So we are using, the theory behind is IL-6 levels are they're measuring, and this is IL-6 blocker. That's what the reason, because it's a cytokine storm which is going to affect the kidneys and heart, etc., and intravascular coagulation. And next person, Vijigar, can you raise the hand for,
Dr. Shiva Erra.
Dr. Shiva Erra, please, sir, ask your question.
Sir, am I audible?
Yes, sir, go ahead.
Sir, one sec, sir.
No problem.
Sir, my question is there any specific protocol for testing IgG and IgM? Like here, some guidelines are given in India that IgG and IgM testing should be done on the patients who are having symptoms more than 1 week, and RT-PCR test to be done on some patients who are having symptoms less than 1 week. Is there any guidelines like that, sir? Are you following anything like that?
You understand, simple, there's so many slides we can present. First, when your patient is infected, you're looking for allergen, like a virus. Virus is RT-PCR. So if you have active infection, you look for virus. Then the virus levels going down, then IgM picks up. Then after it's gone, IgG. IgG is the one which protects long term. So you look for IgG to see whether the patient has immunity. Say if your patient symptoms are present for weeks, yeah, the IgG is the only one we can see. But we want to test COVID positive or not. Of course, we wanted to check for the PCR or either nasal swab or rapid test, looking for allergen. We call allergen is a virus particle. But that sometimes a false positive, false negative. By adding the antibody together, we know get the 100%. That's what the previous speakers mentioned, sir.
So Lokesh Garu, just to clarify, IgM and G, right? So IgM, I sent you one graph, remember?
Right.
So అదేంటంటే IgM 7th day నుంచి రైజ్ అవుతుంది, 21 days కి అది 0కి వస్తుంది IgM. తర్వాత IgG వచ్చి 14th day నుంచి రైజ్ అవుతుంది, ఇంకా అది ఇట్స్ అప్ బికాజ్ ఇట్స్ అ లాంగ్ టర్మ్. సో అది వైరస్ షెడింగ్ అప్ టిల్ 28 days అండి, వైరస్ షెడింగ్. సో a person can be infective up till 21 to 28 days.
One more question, and I spoke to Nageshwar Garu, I think, or someone in Vizag. Those asymptomatic patients, when they track their positive, even though they're positive, they're asymptomatic. After 14 days, almost everybody is negative. But in Italy, where the outbreak came in, after 14 days, 10% still positive. It took 28 days to become almost 100% of negative. But we have seen some reports that virus can be passed in gastrointestinal symptoms in feces up to 6 to 8 weeks. That's what we heard in the different reports. Kalyan Koganti. No, speaker. Kalyan Koganti, unmute. Kalyan Koganti. Okay,
yes,
then.
hi.
Yeah, go ahead,
Good
sir.
evening, everybody. Yeah, having seen the scenario across the world, we have been observing from various short-term articles or to a certain extent good ID consultants across the world. Treatment modalities, especially with respect to starting tocilizumab or starting early heparin therapy. I mean, what recommendations are you? I mean, at what time are you actually suggesting? When are you actually starting them? Like, are you saying that, like, what they're saying is, for now, SpO2 are less than 92% with few infiltrates in the lung, which is usually categorized as category C in India, where category D is a ventilated patient. So there are certain scenarios across the world saying that you start much earlier. How about that? Starting either of these modalities, whether it is tocilizumab or whether it is heparin therapy, or in certain situations we have seen people using even thrombolytics.
I think they're Prasad, you can answer. I think they're starting immediately the thrombolytics like heparin or Levonex, and even I have seen some patients, some of our colleagues in small towns where there is no regulations, they're giving steroids and tocilizumab when they are moderate disease, not into the intubation. And also FDA clearly says plasma therapy at one of the criteria, including 93% oxygen or shortness of breath, they're very liberal. But because of lack of supply, we're not having any studies done in the plasma, moderate disease. And there is a Johns Hopkins protocol. They're doing the healthcare workers in ICU patients, but moderate or mild cases, plasma is not there yet. Those hopefully next 2-3 weeks with supply, we may be able to push that. So most of them, they are doing, it's like a, big hospitals, they're not allowing them to do it because their protocols has to follow. But smaller hospitals, they have more free hand, they're getting those earlier. But thrombolytics are pretty much a lot of people starting. Prasad, can you comment on that?
We are starting heparin anticoagulation at the earliest possible once the patient comes into the ICU. So I think there is no, at least theoretically, there is no big harm in starting the anticoagulation full dose, because we are using prophylactic doses around Lovenox and enoxaparin about 40 or so once a day, whereas therapeutic doses will be higher. If you are concerned about any bleeding complications or reversal and all that stuff, I think heparin anticoagulation is probably better. So I chose most of the patients on heparin anticoagulation. Some of these patients were in the ICU for a few days before I came in. So on all those patients, I converted them from prophylaxis to therapeutic doses just to prevent the venous thromboembolism. What we are noticing is in our cluster of 2 or 3 hospitals that we have here, almost 50% of them are having a DVT, VT, venous thromboembolism. So I think it is going to be a documented, well studied, and guidelines will come out. But at least based on our local information, we are starting the anticoagulation at the earliest possible. Therapeutic doses, not prophylactic doses. The second question about the TOSI, I don't think there is any guidelines on what to do, because IL-6 level monitoring and all that stuff, is there any kind of a lab marker that you can go by to see when it is to be started? But the way we are doing it is not using it on everybody, but elderly people, we are not being that aggressive, and then multi-organ failure, we're not being aggressive. Single organ failure and a young patient without any comorbidities, and we are choosing it because I think if we give TOSI to everybody, we'll be having a limit pretty soon. We'll not be able to have enough supply. So that is about TOSI. As far as steroid is concerned, I think it made sense to me that to follow the lymphocyte count, and if the lymphocyte starts going up on a daily basis and the CRP going up, that is the juncture when you can consider steroids. But as far as guidelines are concerned, SCCM is saying 10 days of ARDS, start the steroids. Sure. So I don't think there is a uniform definitive therapy at this time, or guideline to when to start it.
There's one question here. I think somebody raising the hand, but unmuting. We're trying to ask.
Dr.
Go ahead. Go ahead, sir.
Hello. Good morning, everybody.
Good morning, sir. Go ahead.
So I have 2 questions, sir. Actually, I was in between. I was going out. That's why I couldn't follow you. Are you following any protocols for like screening protocols before taking any patient for surgery? And one more thing, sir. This is not political, but I'm telling you because ours is a newly formed state, Andhra Pradesh. Actually, it was actually not in a position to support all COVID patients also. That's why recently they asked for many of our doctors from Andhra. చాలా మంది వెంటిలేటర్స్ కూడా సప్లై చేసాం సార్. ఎన్ఆర్ఐ హాస్పిటల్ కావాలంటే మా సైడ్ నుంచి కూడా ఒక వెంటిలేటర్ ఉంటే అలా ఇచ్చాం అనమాట. మీరు ఆల్ వెల్ సెటిల్ డాక్టర్స్ ఇన్ ఆంధ్ర, అదే యూఎస్ లో ఉన్నారు, తెలుగు వాళ్ళు ఉన్నారు. సంథింగ్ లైక్ ఇఫ్ యూ కెన్ ప్రొవైడ్ టు ద గవర్నమెంట్ ఆర్ టు ద IMA సంథింగ్ లైక్ some 100 వెంటిలేటర్స్ కానీ సంథింగ్ లైక్ PPE ఎక్విప్మెంట్ కానీ, it will be very nice because in our government or the central government not in a position to supply to Andhra Pradesh the protective equipment or the ventilators. Actually 37 ventilators కావాలంటే Andhra was in ఆల్మోస్ట్ ఆల్ ది డాక్టర్స్ మన గుంటూరు వాళ్ళు కూడా సప్లై చేసాం. ఎక్కడ మా ఉన్న వెంటిలేటర్స్ అక్కడ పంపించాం. సో kindly take it as a request from everybody, Andhra people, try to do something.
Sure, and this location, in the past, the only people who, people are helping whatever the need in the past, like some organizations. Gymkhana, we talked about giving some PPP residents coaching and PG ki raaledanant professor దగ్గర ఉండిపోయినాయండి. They are there only for professors, assistant professor, not reached the house. So we are planning on to give directly to the interns and PGs. Then also there is some ventilators. I don't think they go from here that much because it looks like when talking to Rakesh, looks like the ventilator need is enough and the patients going there is there, but I'm sure in the future they need it. And also even here ventilator, they're going away from the ventilator, trying the BiPAP, CPAP, like that treatment. But other organizations like Tana, ATA, those things also they're trying to do, but their donation will be smaller compared to the resources in India. But definitely, yes, they are coming forward and whatever the little they can do.
The first question was about the testing.
Yeah, go ahead.
So are we doing the testing on all the patients? Is that what you are saying, or are the healthcare workers? Can you please repeat the question? So I'll take it. Basically, what I'm saying is like we are not testing all the patients at this time. We are testing only the patients who are symptomatic, obviously, because you have limited number of test kits available. Number two, as far as elective procedures are concerned, all the elective procedures are canceled at this time. So as each department chief, medicine, surgery, or OB-GYN, they are taking the calls from the doctors. So if they want to do any procedures, so they got to talk to the department chief and get it approved for them to put any case. So like, for example, I approved a lot of the GI bleed cases and foreign body infections and bronchoscopies for our Department of Medicine. So that's how we are doing it. As far as surgeries are concerned, every patient who's going for surgery, non-COVID patient, is getting tested at this time, mainly because we have a 30-minute rapid turnaround Abbott test available. If it is not available, I don't think that's a viable option, because initially they were taking almost like 6 to 7 days for the antigen test to come back, swab test. Now we have a 30-minute to 45-minute rapid test. So we are testing all these elective patients going for surgeries.
Next question is suggestions from Dr. Priyanka, radiologist seems to be. Sir, any suggestions to radiology department working in non-COVID setup, but attending emergencies and scanning pregnant women? Any precautions?
Putting a mask on the patient, putting on mask on the patient is going to be protective only. So in addition to having the healthcare workers having as much of protection, the gloves, the face shields, N95 and a regular mask. So I think if the patient is asymptomatic or pre-symptomatic shedder is giving the viral load out, so that having a mask on the patient is going to be very, very useful.
Yeah, that's what I read, because you cannot stop the patient. You may, in the outpatient side or even radiology, see only the patient, not anybody else, and have them, both you and your employees and the patients should be wearing the mask. That will reduce it, and cleaning the place frequently, maybe 3-4 times a day with the recommended chemicals will help reduce. There's a question about, I think, sir, Dr. Kasula garu, can you ask that question about, did you unmute it, Vijaya?
Hello.
Yeah, go ahead, sir. I think, Nandakishore, you want to?
నేను నందకిషోర్ సార్.
Yeah.
ఇక్కడ ఓపీస్ కొంతమంది చూస్తున్నారు సార్. హలో.
Yeah, go ahead.
సో ఏమవుతుందంటే వాళ్ళు అంటే నాన్ కోవిడ్ పేషెంట్ని చూడమన్నారు కదా, ఎవరైనా ఎమర్జెన్సీస్ కానీ వచ్చిన వాళ్ళు చూసినప్పుడు తర్వాత ఆ పేషెంట్ కి పాజిటివ్ వస్తే ఏమవుతుందంటే వీళ్ళు వచ్చి హాస్పిటల్ మూసేసి వాళ్ళందరినీ క్వారంటైన్కి తీసుకెళ్తున్నారు.
Yeah, that is how you can see the patient, but that's what we are saying. You're risking your life, but take a protective measures. Make sure the patient is a mask. Make sure you see one patient at a time. Make sure you put a barrier. Then that's what we are trying to say. I know you have to start. Lockdown will open up. This COVID is not going to leave us. It's maybe several months minimum, or maybe longer. So you have to protect. You have to see the patient.
One more
అక్కడ
thing,
ఎలా ఉంది
Lokesh
సార్?
garu. One more thing, Lokesh garu. అంటే ఇక్కడ క్లినిక్స్ అంతా టెలిమెడిసిన్ చేస్తున్నారు. ఇప్పుడు స్కైప్ లో కానీ వీడియో కాన్ఫరెన్సింగ్ అట్లా. ఇంకొకటి కొంతమంది ఫిజిషియన్స్ దే ఆర్ సెండింగ్ టెస్ట్ కిట్స్ టు హోమ్ అండి. సో అది నేసల్ స్వాబ్ తీసి మళ్ళీ అందులో పెట్టి మళ్ళీ మనం ఒక డ్రాప్ ఆఫ్ బాక్స్ కానీ ఎక్కడన్నా క్లినిక్ దగ్గర కానీ ఆర్ యూ కెన్ మెయిల్ ఇట్ బ్యాక్ ఆర్ సంథింగ్ లైక్ దాట్ అన్నమాట. అది కూడా చేస్తున్నారు. హోమ్ యూ కెన్ గెట్ టెస్టెడ్ ఫ్రమ్ యువర్ హోమ్. సో ఇండియాలో ఇప్పుడు మనం ల్యాబ్ టెస్ట్లకి ఇంటికి వచ్చి చేస్తున్నారు కదా, అట్లాగే ఇది కూడా మేబీ యూ గైస్ కెన్ డూ ఇట్.
In the future, I think when they have more number cheaper, those passed and negative only they can see as some restriction.
ల్యాబ్ అతను వచ్చి చేసేసి తీసుకెళ్తాడు ఇండియాలో అయితే, ఇక్కడైతే మెయిల్ చేయాల్సి వస్తుంది.
సార్ ఈ రికవరీ ఎలా ఉంది సార్ కోవిడ్ పేషెంట్స్ వెంటిలేషన్ చేసిన వాళ్ళు?
Today, I think there is a Johns Hopkins publisher from New York. There are 393 patients are admitted, and 33% on ventilators. Out of them, 43 are extubated, 33%, 67 still in the hospital. Out of 390, 260 are discharged. This is published as a letter to the New England Journal, just came yesterday.
ప్రసాద్ గారు ఎక్స్పీరియన్స్ ఎట్లా ఉంది సార్? వెంటిలేషన్ చేసిన వాళ్ళు రికవరీ బాగుందా?
Of those 15 patients, we were able to extubate 3 or 4 patients. And I think the biggest thing what we noticed is it is taking longer time. So almost like instead of 2 weeks with any ARDS, it's taking about 3 weeks or so for these people to get extubated. A lot of the times if they are already on some muscle relaxers or paralytic agents, they are extremely weak. Even though they recovered from the ARDS point of view, they are not able to come off of the ventilator. So those are the issues that we are seeing. But I think after my 7 days of ICU shift for that week, I felt very confident that this is like any other condition that given the lack, I mean, if we have enough number of ventilators, I think we should be able to manage this condition like we manage any other ICU population in a way. The problem is if you have we have a maximum of 70 ventilators in 2 hospitals that we serve. And if there are more number of patients and each patient is taking up this ventilator and ICU bed for about 3 weeks, so suddenly you will be having patients who need it, but they don't have the ventilator. That surge capacity is the biggest problem. Below the surge, I think it is like any other condition. And the other data said is like we are able to extubate and get them off of the ventilator at least about 3 to 4 per week. So I think we have a good mortality rates are somewhere around 50% per some studies, but our mortality is lower than that. I'm glad to say that, but it also depends on the patient population that you have.
One more thing I wanted, once the antibody test comes, say for example in India, so you have a lot of people who are positive antibody is good. So you can hire them in the hospital. They're your protection. They're your vanguard. So I'm sure even a lot of doctors already are healthcare workers are positive. So you can use that as a strategy to help in your office. And then you can use the barriers. Like my office, I use them, but I talk to them on WhatsApp when they're in the room, other side. And then my contact is very minimal. But we have not closed. I think we closed 1 week, but we started seeing patients. And our allergy shots every week. My office patients was their allergy shot. They put a plastic barrier and they give the arm through that, and protected by a mask and the shield. So we're continuing the shots. And my risk factor, when you go to grocery store, the risk factor is same as patient coming to the doctor's outpatient office. That's what we're trying to minimize as low as that. So even in lockdown places, now people are going 2-3 hours to the markets and they're getting their vegetables or whatever. So that risk should be an outpatient or radiology should be that low if you follow these small precautions. Narendra Reddy are asking a question. Is he raising the hand, Narendra Reddy?
Yeah. Yes.
Go ahead, sir. I think the audio is not good.
Hello.
Yeah, go ahead, sir.
Can you listen me, sir?
Yeah, go ahead, sir.
Sir, I'm an orthopedic surgeon.
Yeah, go ahead.
Yeah, the scenario, the present in Guntur is our testing levels. We are awaiting tests from last 10 days. So a lot of samples has to be screened, and we are not yet started the screening of rapid tests. We not yet started because the kit in Guntur. Seriously wrong in because the mortality rates what we see in India and in US they both go same mortality. But what went seriously wrong in US, which we should learn from our experience?
I think I
Rakesh
did.
garu.
Yeah, go ahead.
Yeah, so US lo cases ఎందుకు ఎక్కువ ఉన్నాయి
What we
ఇండియాలో?
can learn.
Yeah, so because US population is different from India అండి. US లో బేసిక్ గా ఇన్ఫెక్షన్ ఇమ్యూనిటీ తక్కువ, ఇక్కడ మామూలుగా ఇన్ఫెక్షన్స్ చాలా తక్కువ. సో దట్స్ ద రీజన్ వై పీపుల్ గెట్ suppose some infection like this comes up, they do not have that better immunity in US to infections. Second thing, in India, why it is low? There is one explanation that BCG is protecting them. We are not sure, but BCG vaccination, 15 to 20 years, it's good. After that, it's not good. So there is a vague study, one study which said that BCG is protecting people from India. But also the stay-home orders, everything. India was a little bit way ahead of the isolation and all that, social distancing and stay-home orders strictly. So that's also protecting one way in India. Versus in the United States, travel, a lot of people came from all over the world, mainly from Italy. ఇక్కడ ఫెబ్ మార్చ్ స్ప్రింగ్ బ్రేక్ టైమ్ చాలా మంది వెళ్ళారు వచ్చారు. Infection came from Italy, mostly travel related, and 350,000 people almost came from Europe and other parts of the world where this virus was more. So that we were too late, and it was very fast transmission also. So before we opened the eyes, it was already widespread in the community. So infection immunity takwa plus exposure ఎక్కువ ఉండింది. Within 1 week 10 days లో it went rampant here. New York very crowded kuda, New York City like Bombay laga.
The other, I want to add, Narendra Reddy garu, the people who died, like I took the Detroit statistics, Michigan, which is 10 lakh population, 2,000 people died. 80% are age 60 older, 65 older, 80%. So that population we don't have, we have lesser. India is a lot younger, and but they did early lockdown. So we have to see what happens next 4-5 months. So we're not early to say this is a virus which is a several months issue minimum, maybe longer. So we're early phases. So we'll answer some of them.
Even Italy kuda ante andi. Italy also older population was higher. That's why their mortality was very high.
And one more thing in Germany is what they did is they did the Indian method. They locked them earlier. They put them in the hospitals, so they're not exposed the older people. So the death on the older people, that's how they prevented not exposing the older people. Or in America, when they're sick, they're sending home, and the grandparent is dying. So same thing. Even in the future, if you look at your Indian numbers, I'm looking, most of the older people they're the ones who are going. Rakesh, do you want to add anything here, sir?
Absolutely. Even for the mortality that we had in India is the elderly population, especially with the more comorbidities. And we do know that India is a hub for diabetes mellitus. Many patients are diabetes, and some amount of glucose management is a big issue. So probably that group of people needs to be taken care of. And that is actually what is happening during the lockdown period. So probably we'll be able to save them, and probably that is the reason that lesser number of patients are on ventilators and more number of patients are young, asymptomatic. Almost 60-70% patients are somewhere less than 60 years as of now.
Yeah. So that's we're going to see, and it's going to, Rakesh, can you give your closing statements? I think you Thank you.
All right. So, thank you for inviting, sir. As of now, I think the lockdown principle is benefiting a lot. This is one. Secondly, as Dr. Anupama also mentioned, probably the number of moderate to severe category cases are much lesser in India. But yes, we need to be looking for the surge that may happen once the partial relief of some component of lockdown will be released from tomorrow, that is 20th. So we are looking towards that aspect. We'll be using the rapid antibody testing from the cluster and cohort. The principle of complete lockdown, sealing is working well, and the identification and screening is much happening at a more broader level. The dynamics are changing every day. We hope things should settle down, and the Indian resources will be able to manage the number of cases that are coming up. And we are able to a little plateau the curve as of now, and we wish that they will remain like this.
Thank you, Dr. Rakesh. Prasad, do you want a closing comment?
Thank you again for API and also the IMA for giving this opportunity. So my comments are basically, I think the best time to have the map is before we get to the woods. So I think just because the numbers are low at this time, come up with as much preparation as possible. Volunteer, you don't need to be in the site, but at least, wherever you are, you could possibly get the right protocols made for your place of work, whether it is private or government. I think that is the key. I think as healthcare providers, I think if we direct them, and we will be able to get the whole noise down and more signal spread. So I think that's the key, because there is too much of noise than the signal. That is going to be a double whammy, and it's going to cause more harm. And I think as healthcare workers, I think if we all take this up and then come up with nice guidelines, protocols that are applicable locally to our places, I think we will be guiding the people and leading the people in the right path. Thank you.
The other, Dr. Chakra Garu, can you unmute yourself so you can give a statement? There's one question here: how is the dead bodies are disposed in USA? That's a big question, and it is so insane that the orthopedic doctor's situation, what we hear in the news. Like in China, if you provide the drivers who take the bodies or the cremated, they can be safely disposed of, whichever the custom they have. In our Indian customs, so they can cremated or versus so other options they choose. As long as every district have like 10-15 people are well protected with complete Ebola suit, they can respectably send off those not made through the COVID. Dr. Chakragara, you want to say anything?
Nothing, sir. Everything is going on well. Actually, there is not much need of ventilators and other things here as per the volume of cases that are being diagnosed and coming to the hospital. Even in the morning, I had a meeting with the All India Anesthesia Society. Many of the people are telling that they have less number of cases, but in Delhi and in some northern cities, they have more cases, and definitely they are doing. Especially in Andhra, there are no cases on a ventilator till today. It's going on probably after 20th or even 3rd May, the cases may increase. At that time, I think everybody will cope up with everything. And the Indian Society of Anesthesiologists has released about 52 lakhs for its city branches to purchase the PPEs and masks for their members. So that is the things going on. And here, actually the PPEs are not available. Nowadays, they have started stitching and manufacturing the PPEs. Probably in 2-3 days time, I think there will be enough PPEs. But the problem here in the mentality of the people is the head of the department, they keep it in the cupboard and they will not give it to anybody. But here in Kakinada, we have given directly to the residents the masks, and we are trying to cope up with the things, what are the lacking there and all. There are some issues that N95 mask is not given to anesthetist and all those things. And of course, they will be sorted out soon.
Sure.
There will not be much problem here.
Thank you, sir. One more question. There's one N95 because you cannot buy again and again. How do you, Prasad sir or Rakesh sir, can you N95? How do you sterilize?
So right now, what we are using, the AIMS has come up with the policy. Those who are not working directly in contact with COVID positive patients, I mean the other parts of the areas, we are using a 5 mask technique. So everybody, the healthcare worker is being given 5 N95 masks and 5 polypacks. So they use one mask and keep it for 4 days, and they are using it by rotation. So that is for healthcare workers in non-COVID areas, as we were discussing. And for COVID areas, I think we have to use them because there are a lot of aerosolization and everything is happening. So we are not reusing them. So the policy is coming up. In case if something happens, we look forward. But right now, the recirculation every 5th day could be the one option for the healthcare workers.
So outpatient doctors and their employees can do the same thing. Every 5 days they can change. And Prasad?
One more thing on the N95 masks. So what Dr. Rakesh Garg said. The other way you can even sterilize is steam it. Steam it for 30 minutes, put it under a steamer, and with the steam, the mask can be sterilized without causing much damage. But each mask can be used 3 to 5 times maximum.
For the healthcare workers, I know there is, in India, there's less number of ventilated patients, but the biggest problem is going to be asymptomatic people who will be spreading, especially the lockdown comes out. And I think that is the reason why I think it is very, very important. Personally, I feel a lot more secure in the ICU COVID unit because it's all negative pressure. I have all my gear with me and it is being cleaned regularly. And the patient is completely isolated with a ventilator circuit that is going outside. Whereas I'm very, very cautious on the floor because you do not know whether the nurse who had a COVID, who is asymptomatic, is spreading it. So the telephones, the keyboards, the mouses, the floors, they're not wiped carefully. So I'm a lot more careful in that scenario in the regular floors where they are non-COVID floors. But I think the risk of transmission is a lot more in the non-COVID floors because of the pre-symptomatic and asymptomatic patient. So I think that's one of the important factors that I'm going to, important messages that I'm going to give to people in India is basically just because your numbers are low, that doesn't mean that you don't have asymptomatic carriers. So I think that is very, very important at this time for the lockdown to be effective. It's very important that nobody does anything at this time unless it is absolutely essential and urgent and important. And until they don't do it, then it is kind of creeping along. And once it creeps along, it's hard to manage.
Thank you, sir. Dr. Nandakishore, sir, can you wrap it up? Thank you so much for giving the opportunity to us to share in with you. Dr. Nandakishore Garu, IMA President. Sir, you have to unmute Dr. Nandakishore, he's speaking. Yeah, Speaker Dr. Nandakishore. Yeah,
sir,
go ahead, sir.
Thank you, sir.
Yeah.
Thank you for sparing your valuable time. Prasad Garu, Anupama Garu. Dr. Rakesh, sir, thank you very much for joining in this program. And the participants also, thank you very much, sir. And Lokesh Gari, the trial laga cheddam annaru. If everybody is interested, sir, and other people are, they want to conduct it regularly with various specialty people. So kindly spread this word to other people who has not joined today. So we can exchange the knowledge directly from the people who are treating in USA. So Lokesh Garu is ready to coordinate the program. So finally, thank you very much from IMA Guntur to all the speakers and participants, sir. Thank you very much.
Thank you.
Good night, sir, and have a nice day, sir. Prasad garu, Anupama garu. Thank you very much.
Good night. Thank you.
Thanks, sir.
Thank you.
Bye.